So good afternoon. I'm Laura Siminoff. I'm the Dean of the College of Public Health at Temple University. And welcome to our continuing series, COVID-19 Beyond the Biology. Today, we are exploring how one of New Jersey's largest health systems is handling the COVID-19 crisis. So I'm very pleased to welcome our three panelists from Virtua Health. Virtua is South Jersey's largest health system with 5 hospitals, 2 satellite emergency departments, 8 urgent care centers, and more than 280 other locations. Lately, Virtua has been in the news because of its central role in the national public health emergency. Virtua has been employing a cutting-edge, data-driven approach to the treatment and care of COVID-19 patients, including providing testing for their communities. So I'm extremely honored that they have taken time to talk to us today. So with me are Dr. John Matzinger, the Executive VP and Chief Operating Officer of the Virtua Health Network, Dr. Emilio Mazza, a Pulmonary Critical Care Specialist at Virtua Health South, and John Kirby, a Senior Vice President and Chief Operating Officer at Virtua Memorial Hospital and a Temple CPH alum. So welcome everyone. Now, you've accumulated so much experience with COVID-19 in such a short period of time. You are doing great things, and I know our audience will be really wanting to delve into the details. So my first question is to Dr. Matzinger. I understand that Virtua, being the largest health system in South Jersey, continues to provide for about 50% of the COVID-19 patients in that region. Can you give us an overview of the general approach you've taken to this health emergency?
Sure, thank you, Dean Siminoff. To tell you our world changed in the end of February, beginning of March would be an understatement. And it really kind of went on like a light switch because of what was occurring in northern New Jersey. We saw what was occurring in New York City, northern New Jersey, and at that point, along with most of the Philadelphia institutions, we stopped doing elective surgery or scheduled surgery on March 6th. That was really twofold. It was A, to start to look at what was going on in the environment, and B, to really preserve our personal protective equipment, because as everybody was experiencing at that time was a shortage. So we spent a lot of time looking and really starting to act as a system. Every day our leaders are on the phone going through what we call as a state of the house and spending time really drilling down how many patients we've tested today, how many patients are under investigation, how many patients are coming in from nursing homes, really looking at our entire integrated network and where we're seeing hot spots. Okay.
So I noticed that you've opened up some testing centers, and I'm wondering how you've been able to handle the supply chain issues and what actually is the availability of testing for residents in New Jersey, or at least in your part of New Jersey.
Absolutely. We've opened up 6 testing centers since the beginning of March. We have opened additional testing centers, decommissioned testing centers, depending on what was going on in the community at that time. So right now, we currently have 3 testing centers online. We have one servicing the Voorhees-Marlton area of Camden County. That's a drive-through testing center. We have stood up our access center to take in all calls, so people will schedule so that we can have controlled volume. But that's, you drive in, you get tested, you go out, and we basically call you with your results within 24 hours. We, in coordination with Cooper and the Camden County officials, have opened 2 testing centers in Camden, New Jersey. We had one we decommissioned last week and opened 2 additional to service other areas of the county. That is a walk-up testing center as well as a drive-up testing center. And we really looked at that because of some of the challenges with transportation in those communities. That's also why we decided to move the testing centers around every couple of weeks, because Camden is a truly walking city because of the way public transportation works. We have seen tremendous results in that some days we're testing well over 160, 170 patients between the 2 testing centers. Our 3rd testing center really is focusing on Burlington County. It's currently in our Willingboro location, and it's a drive-through testing center with scheduling. We also do allow for walk-ups at Willingboro because Willingboro does have a similar population When you look at it from a public health distribution, like Willingboro, I like Camden City. So we do have to allow for some walk-up registration at that point. When it comes to the actual testing and supply chain, it's gotten better. I will tell you, in the beginning of March, it was, it's still a full-time job, but it was a full-time job plus. In the beginning of March, we spent a tremendous amount of time trying to procure testing materials so that we could get the appropriate tests back. We are, I would say we're almost agnostic at this point. We're working with LabCorp, Quest. We have internal testing. We're using 3 different platforms internally. If we can get the material, we do the test at that point. But knock on wood, it's been going very well. We've tested over 12,000 people since March 1st.
Well, I know I'm all excited to hear that, to be honest.
Mm-hmm.
I also saw that you're offering free virtual visits for
Yes.
COVID-19 symptoms, and what motivated you to do that?
Well, I think we need to do it twofold. We need to service our community, but we also need to deal with the worried well. We didn't want to become overwhelmed in some of our access sites because people are watching the news, TV every day. It's scary. I mean, Emilio's on the front line. He can tell you how scary it is. But what we saw in the first couple of days is this rush to get testing. We have probably one of the most mature access centers in the country. We've been doing it for about 15 years. We were overwhelmed in the first 2 days. Our average time to answer a call on a normal day is about 15 seconds. People stay on the phone for about 90 seconds to 2 minutes. Our wait time went up to 2 hours because of just, we got inundated with calls. We could not handle it. So we took a step back. We introduced a whole clinical triage arm. We introduced telehealth, and we basically put people through screening protocols. We introduced chat bots on our internet and intranet so that people could answer their questions and really start to farm out who needed to be seen quickly, who had mild symptoms and didn't need to be seen at all. We could just give advice to via telemedicine, and then who were the worried well. I will tell you that was probably one of the more challenging things we've ever stood up. We, like everybody else, had dabbled in telemedicine. We've done over 100,000 telemedicine visits in the last 2 months. So we went from essentially 0 to 100,000.
It's been a stunning change, hasn't it? From everybody's perspective. The last thing I just wanted to touch on with you, just to get your thoughts, is the announcement of this 7-state consortium, of which New Jersey and Pennsylvania are a part, to meet the supply chain and the testing challenges. And have you started having any experience with that? Has that been stood up yet, or is that just currently the plan?
Yeah, absolutely. The governors have been speaking, as well as the elected officials. They have been clear that they're working in concert, but they also will have to work at different paces depending on where different regions are. As you're well aware, Pennsylvania has opened up scheduled surgery. New Jersey's probably about a week, maybe a week and a half away from that, knock on wood. New York has some criteria depending on the counties and the prevalence of disease in the counties. Where we've spent a lot of time, New Jersey was separated into 3 regions very early, and the regions are working together. So the 7 southern regions of New Jersey, we have a call pretty much daily between the medical side, the operational side, and the CEOs talk twice a week to make sure we're in concert. We did all of our surge planning together, and where appropriate, we're doing our testing together. We're working closely with Cooper where we overlap. Jefferson, New Jersey opened the other Camden County site that was closer to them. So we've really, it's probably the one time where we've put all health systems and put competition aside and figured out how to, treat the community as a large whole. And it's, we've known these people for years. We have good relationships, but it's like, okay, you guys handle this area, I'll handle this area, and we'll meet in the middle. And it's really helped us stretch our resources.
Okay, well, thank you. So I wanted to turn to Dr. Mazza. He's a leading pulmonary critical care specialist, and obviously from the way he's dressed, he's in the thick of it. So I know this may seem odd to ask you because the answer is obvious, but can you talk about your experience treating COVID-19 patients and and what you've had to do and how you've had to alter what you do in order to provide care, not only to COVID-19 patients, but you continue to have other people who don't have COVID-19 who obviously need care from you as well.
Well, first of all, I want to thank you for inviting me to be part of this session. Yeah, I mean, it's really, where do we begin? You know, this disease is a respiratory disease primarily. Patients are, are coming in anywhere from requiring, a couple liters of oxygen to being on a ventilator for a long time. In the ICU, the average length of stay, probably worldwide is about 15 days of being on a ventilator, which is a long time. But we have some people in our ICU on a ventilator now 21 days to up to, I think one's 28 days. So, the patients are sick and they're sick for a long time, and it's a disease that's very slow to resolve. These patients present with what we call silent hypoxemia, where they're sitting there like us here on the Zoom session. You couldn't tell their oxygen levels are low, but when you go and measure, they're 85%. And this is one of the very strange things of this disease and what it does to the body. So this is something like none of us has ever seen before. Even early on, we were told, patients were developing what we call, whatever he's describing as acute respiratory distress syndrome, or ARDS, but it's not even typical ARDS. It's very, very different. We're seeing, it's a very different from what we're used to seeing, like say with the H1N1 pandemic that we had, several years ago. There they had true or typical ARDS. This is a very different presentation. Their x-rays don't look as bad as they are. And that's the thing we've been trying to all figure out along the way. Things that in terms of treating them, what we found has worked so far. And I have to say, I can tell you how many different, this has all been one big scientific experiment, really, because no one knew how to treat this virus. And we're basing a lot of our experience off of Chinese experience, the Italian experience, and Europe's experience, and also Washington and other areas of the country, and New York especially. What we've been finding has been working. We've been putting a lot of these patients on steroids because a lot of these patients develop something called the cytokine storm, where the virus triggers this massive immune response in their body that causes all sorts of downstream effects. It affects the way the lung functions in terms of the blood flow through the lung. You can get blood clotting, which we're seeing, which they develop what we call hypercoagulable state, when they can clot in different areas in the lung, kidneys, brain. And there's young people with mild symptoms now that are reporting having strokes. And we've seen some very strange neurologic presentations in young people. And it's probably because of this hypercoagulable state and the cytokine storm that's even causing even autoimmune processes to be kicked in. It's something like we've never seen before. So we've put patients on steroids. We put them on full dose anticoagulant because of the blood clotting issue. The infectious disease docs have tried different things like retrovirals like you would use in HIV. And of course, there's remdesivir, which is the more recent, got a lot of press. And the initial analysis was promising. We'll have to see what the final analysis is when all the data's in and they do all the, all look at all the different covariates and see if they can tease out what remdesivir really does. Is it going to be like Tamiflu and shorten symptoms, but not really change mortality? We'll have to wait and see. The other thing that, and actually our Voorhees campus was a site for the trial for remdesivir. The other thing is the convalescent plasma. I know it's another thing that was a topic that people ask about. And again, we did those two cases that was actually in the news. I think it made it to the Philadelphia News of two patients who received convalescent plasma. And the jury's still going to be out on that yet either. Now, Mayo's running a very large trial that we're part of at Virtua. One of my colleagues is actually, Dr. Poliskowitz is actually one of the lead, he's our lead guy here for running that trial. And we'll have to wait and see, because again, the problem with this virus, it's so unknown. Is one person's convalescent plasma, is their antibody effective against the virus that you have? No one knows this. There could be different strains of this virus, and they're already talking about mutations occurring already. So that's the thing that we have to wait and see when the dust settles eventually. A lot of what we're doing, we're throwing everything at patients that we think could have biologic plausibility. And that's why this is a whole new experience for all of us doing this.
So I'm just wondering, just from something you just said, that patients come in, they're not even aware sometimes how sick they really are, and they kind of deteriorate frequently very, very rapidly. And yet what we're doing right now is telling everybody to stay home, take care of yourself, you know, as much as you can. And then when you have these more severe symptoms, come to the hospital. And I'm just wondering whether maybe some of the things that you were talking about, like steroids, whatever, maybe those should be done earlier on in the course of the illness to prevent like the cytokine storm. And is anybody looking at that? Are you looking at that issue?
Well, that's, you know, those are great questions. And that's the one thing. I mean, really, should remdesivir be started when you first start having fever, starting like you would with Tamiflu, right? You get the flu after 48 hours. Tamiflu is not really effective after 48 hours of having symptoms. Should it be something like that? But unfortunately, because of the way remdesivir was doled out in the trials, they really saved it for the sickest patients. And myself and one of the oncologists were actually just talking, and right before the meeting, maybe that should be given up front. Knock that virus out, kill that virus before it gets into cells and causes problems, so you don't get the cytokine storm and all the subsequent problems. Maybe we should be early. Maybe we're looking at the wrong patients. Even the convalescent plasma, should we be giving it up front? When patients first come in and they've got a little bit of hypoxemia, they're having fevers, give it then, not wait till they're on a ventilator and the horse is out of the barn and running. And I think those are very valid questions. And I think that may come out. My concern with the remdesivir trial is they had included a broad spectrum of patients, but most of the patients getting it are later on. And maybe it would have been more powerful if it was up front, early on, before we had all the other secondary effects that come, the blood clotting, hypercoagulable state, the cytokine storm. And that stuff that's, again, it's just such a fast moving target and hit us so quickly,
So have you been experimenting with some of these positioning issues of sort of changing up the positioning of patients?
Yes, we have. We actually been doing what, it's called proning. And this came out in a large trial in 2011 in New England Journal, where they found that proning in patients with ARDS had a survival benefit. It reduced mortality. But like I said earlier, this isn't typical ARDS. And even Dr. Gattinoni, who's the father of proning, even in a more recent article said that there's a moderate benefit because this isn't the typical disease. I will tell you from our own experience, we've been proning patients and their oxygen levels do improve. Ultimately, has that reduced mortality for us? I'm not sure, but we really have, because proning involves a huge process. I mean, they talk about on TV like, oh, you just flip the patient over. When you got somebody who's got a tube in their mouth, all sorts of lines coming on a dialysis catheter in their neck, another IV in their neck, which giving them all these medicines to support their blood pressure, and you're turning them. Bad things can happen when you do that if you're not careful. And then you're talking about 4 or 5 people going in the room to do this. That's a lot of PPE. And that's where you're balancing out the benefit of doing that versus the use of personal protective equipment that we were very worried we may not have, as exactly what happened in Italy and probably was happening in New York. And so you're really trying to pick the right patients to do this that you think are going to benefit. And there are some side effects of putting somebody on their belly. If they're especially some of the meds we're using, it slows their motility of their GI tract. Some of them are vomiting when you put them on their face, and that can be a disaster. So it's not so easy. It's easier said than done, so to speak, when you hear about it on TV. And we've been trying to do even non-intubated patients, having them lie on their stomach. And you do see that their oxygen levels do improve, and some people tolerate it. The morbidly obese patients don't generally, because it does put a lot of pressure on them. They just can't breathe as well. But we have a protocol. We've been doing that as well.
So I just want to ask you one more question very specifically. So a lot of people listening to this, Dr. Matzinger talked about the worried well, but there's also the worried, maybe I'm sick, maybe I'm not, I have some symptoms. I think people would love to get guidance from you in terms of thinking about how they can evaluate themselves to say, what are my symptoms? My allergies? What's going on with me? And then what they should do about it. I think a lot of people are still in the dark.
Yeah, and the problem with this disease, it presents in so many different ways. And just to give you an example, I mean, one of our colleagues, one of the docs that I know, his only symptom was loss of smell, and he kind of noticed it. And then he talked to one of our ID docs, said you should get tested. Sure enough, he was positive. That's all he had. Just lost the smell. There are some folks who are getting maybe a little headache, congestion, earache, ear congestion. Those are allergy symptoms, right? I mean, we all get them, right? Especially this time of year, you got pollen around. Yeah. So it's hard to figure out what's what. And you get a little cough with that because you have postnasal drip. Well, is it COVID? Is it that? And that's what makes this very difficult. I had one of my patients yesterday. I was doing a telehealth visit, and he just happened to get tested. And it just happened to come back at the time that I was on the phone with him. And he has bad emphysema. And he said, Doc, what do I do? I said, well, check your, he's got a pulse ox. We're checking their oxygen at home. And I know Virtue's been doing that when patients have come to the emergency room, giving folks, if they do discharge out, a pulse ox to measure their oxygen levels and keep track of it to see if they're dipping down over the course of the day, measuring it, 3 or 4 times a day. And that's exactly what I told him to do. Watch his symptoms, taking his temperature, and see if I told him if your pulse ox starts dipping down, if you're normally 95%, you're starting to end up 90, 92, 90%, and then you start going below 90%, you got to come to the ER, because that's when that's what I worry about, the cytokine storm and all the other effects that could start to happen at that point.
Well, thank you. I mean, an allergy sufferer, sometimes you wake up in the morning, you're saying, okay, what is this right now? So,
is it COVID or is it allergies?
Exactly. You can hear in my throat, I have allergies. So, John Kirby, so this is an epidemic that's clearly overwhelmed a lot of hospitals. And I'm wondering if you could tell us a little bit about how you're faring and just give us a little sense of, on a day-to-day basis, like how many patients you're seeing, what's it look like for you all?
Sure. Yeah, I'd be happy to. So, overall, I think our staff is faring very well. It all starts with the leadership, like Dr. Mazza, Dr. Matzinger, the way, the operational meetings that occur every day as we plan through this, that is pushed out, and everybody from the 5 hospitals that you mentioned participate in, and then to our clinical leaders like Dr. Mazza. Where Dr. Mazza works every day is, the epicenter at my hospital, Virtual Memorial, where we're handling the majority of the sickest patients in the system. So the ICU is a 26-bed ICU, and it was filled. There were many days it was filled with ventilated COVID patients. And as Dr. Mazza mentioned, they had a longer length of stay than you normally would see. And so they were there for, several weeks. We had to make some operational changes in the organization to accommodate this, because we're, still open to the community and a full service hospital. And so we have other patients coming in at the same time. So, one of my colleagues here, our local nursing officer, stood up a non-COVID ICU with Dr. Mazza. So we had to take a med-surg floor and staff it a different way, put some different equipment up there, and we created a non-COVID ICU so that we could separate the COVID from the non-COVID population, and even separate the providers in those 2 areas. And then and then eventually we ran out of beds there, and we had to go to a 3rd ICU. So we had to pick a 3rd location for overflow. And again, Dr. Mazza had to staff it, nursing had to staff it, and we had to make some changes. And we just closed that down yesterday. So, we're seeing the volume. It feels a bit like we peaked here, and we're seeing the volume, especially of the more critical patients, starting to subside a bit. Some of the other changes that we've had to put in place, I made it sound kind of simple. Melissa, Zach, and Dr. Mazza chatted and opened up a new ICU, but as we spread patients out around the organization, some of the challenges that an acute care hospital has is that in an ICU, you have clear glass doors, so you can constantly visualize the patient. And in the med-surg areas that we converted, we didn't have that. So you have solid doors, and you're keeping them closed because of the isolation precautions. So we had to make a change and cut some windows in, and we had those installed in the process, which, that request really came from one of our sister hospitals and our clinicians, because they started it there, and it has certainly made it a little bit easier. So they're just some of the challenges that we've had to rise up and meet in the moment as the community demand increased.
Did you have to do anything like change your ventilation system or other things to make sure that you weren't distributing the virus throughout the hospital? I mean, are there other things you generally had to do throughout the hospital?
Yes, there are a number of things. The first challenge that most hospitals have in America is the lack of private rooms. So we run semi-private rooms. So you have some rooms that are private and some that are semi-private. Additionally, within our units, we have what are called negative pressure rooms. So normally when you're handling infectious disease type disorders, TB is an example, you would put that patient in a negative pressure room, which, exhausts the air outside of the room. It doesn't go into the hallways or into your organization. So we certainly utilize those as a first option when we were putting COVID positive patients in them. Then we had to start utilizing other types of air purifiers like a HEPA filter. Dr. Matzinger and the folks in our central procurement office actually had to go out and on a weekly basis we're renting or purchasing HEPA filters, because we made the decision to put HEPA filters in rooms where we didn't have a negative pressure capability. So we didn't have to adjust any of the overall ventilator systems of the hospital, but we did make some of those changes. On top of that, we had to make some other operational changes, and one of those was implementing a visitor restriction policy. So we have very limited exceptions, and it was something that the head of our infectious disease group helped facilitate along with Dr. Matzinger to kind of set some guidelines, and then all the hospitals implemented them. And the community went along very well. They understood the implications of that, and then we just have certain modifications and exceptions that we can make based on it. For example, a pediatric patient that comes into the facility, needs a parent with them to stay with them while they're here.
So everybody's found out what the term PPE means now, right? So everybody's familiar suddenly with that. At the very beginning of this, I know as a public health professional, we urge the public not to buy masks and stuff, but now people are being urged to wear them. Have you had trouble getting PPE? Have you been trouble getting sources for that? What have been your challenges?
John, you want me to take this question?
Yeah, that'd be great.
I feel like I live this every day.
You do.
Yeah, PPE, it was an interesting challenge for us. I mean, we're a large integrated health network that sends personal protective equipment on a normal basis all over the place. What we saw in mid-February is that our normal procurement, and we run our own supply chain internally, wasn't able to get shipments out of China. So we started tracking our masks as we were watching what was unfolding on the West Coast, and we noticed our N95s were getting lower, or basically everything we needed. At that time, we started trying to go to secondary markets and other distributors, our non-traditional distributors, to obtain PPE. And the market, there was no market. We spent a tremendous amount of time doing it. An example would be something like an N95 mask, which obviously you hear all over the news. That usually is 50 cents to procure. That mask in the beginning of March went up to $5 to $7 per mask. So, we spent a tremendous amount of time, and I really do give our supply chain colleagues credit. They have turned every stone known to man, and I would say by the middle of the first week, second week of March, we started to get our PPE levels back to where they belonged. We masked all of our staff, make sure that we had N95s in any high-risk areas or anybody who was treating a COVID positive patient. It really, I've never seen anything like it. And what you're hearing on the PPE side, you're hearing about the masks, but the supply chain goes much deeper than this. And I know Emilio was dealing with this quite frequently. A lot of the medications we use for ventilated patients became very short supply overnight because of the burden of narcotics, as well as the burden of sedation medicines. So we started to notice there was a shortage on that. We started working that very diligently. But I will say the public has been great. Also, we've had a lot of donations of N95s, whether they be from an organization like Habitat for Humanity. Subaru donated masks to us. So we were able to stock it on our own, but it never hurt to get additional supplies from others. But we watch our supplies literally on an hourly basis. I can tell you how many large gloves we have in place right now because I'm getting fed that information constantly.
So ask some questions for all of the panelists. Do you believe your hospital has experienced its peak of cases?
Yeah, I mean, we're looking at this throughout the day. We're watching our emergency rooms. We think we experienced our peak about 15 days ago. We have seen our cases and our patients under investigation drop over the last 12 to 13 days. We had 10 consecutive days of drop. We saw a slight bump of about 12 cases and stayed stable. And now we're starting to come back down. But we do think we've seen a drop in our cases. Now, what I will tell you is I think we will continue to see positive cases as we expand testing into the community, but we are seeing a decrease in hospitalizations, and I would let Emilio and John speak to their building, but even some of the acuity in ventilators has decreased in the last week.
Yeah, what have you both been seeing?
Yeah, I've been seeing that we're not, the acuity, the patients aren't as sick as they had been. We're not seeing as much in terms of the number of patients on ventilators, so that has gone down.
So why do you think?
Yeah, just given.
I mean, why would the acuity of the patients be going down?
I think one of the things that I think one thing I hope is that as the patients are coming in, because what we generally see in the ICU, it's rare we get somebody from the ER up to the ICU in respiratory failure. The usual way that it proceeds is the patient goes to a medical surgical floor bed, and then we're watching them, and then what happens? They start to either get better, and they go home, or they get worse, and that's when they come into the ICU. And I think we're understanding this a little bit better. People are kind of getting in the groove of knowing what to look for. And I think we're getting very aggressive, like with steroids, anticoagulation, other things right up front as soon as they're coming in, and not waiting for the horse to get out of the barn. And that may be part of it. And I think it's the recognition, the testing's coming back much faster. I mean, when we started this, it took sometimes 7 days or more to get the testing back. Now we're getting the testing back within 24 hours, probably even less. I've seen it within the same day, we're getting the results. So I think that's helped us. And we've, and I think people are much more aggressive. We're understanding this as we're going along. And I think that's probably helping. And also I think with social distancing and the things that people are doing, we're not seeing as much in the community as a lot of the cases we're seeing coming from nursing homes and that sort of place, which everybody knows about from the news. I mean, that's no surprise. It's no secret, and I think, I think that's helping a lot is the social distancing and patient and isolation. That's really helped flatten the curve, as everybody says.
Right. John, what were you going to say?
Oh, yeah, sure. I was just going to add a snapshot from today. So we have 79 COVID positive patients in-house, 16 what we call PUI, which is a patient who's under investigation, which means we tested them and we're waiting for the result to come back. So that's in total, we're treating 95 patients with COVID precautions on a census of 235. We certainly have been higher, and as both Dr. Matzinger and Dr. Mazza said, the acuity seems to have come down a bit just by the number of ventilators that we have in use every day.
Well, I mean, that's certainly good news to everybody. So thinking about that numbers are going down, thank goodness. But the prediction is that we will see at least another wave of this, probably in the fall. So how do you see handling this, like your lessons learned from this? Are you going to just hopefully go back to normal operations, or are you going to normalize right now, but keep in place some things in anticipation that in the fall we could see a resurgence of this?
Well, I mean, I can start. I don't think we're going to go back to normal operations. I think normal has changed. Amelia could comment on this. Back in the 80s and 90s, when HIV came onto the scene, our normal changed. The way we use PPE changed. I do believe we're going to see this undulate for a while. There's not a vaccine. There's not herd immunity. We don't know what antibodies do right now. I mean, the jury's still out on that. We will have flu season coming at some point. Some of the things we're talking about is starting our flu vaccination program, because we have mandatory flu vaccination, actually starting that in August. Before, we would normally do that in September, October. But a lot of the models, and there's a lot of models to look at, show this long, prolonged, undulating course. I think you're going to see people walking around in masks and goggles in our hospitals, just like you see a stethoscope. I think that's going to be part of the garb we wear.
Anyone else have thoughts about this? Yeah.
I agree with John. I mean, that's, I think, we're going to have a new normal for I think for a long time, both outside the hospital in the real world and for us. I mean, we're going to be wearing goggles, masks, like John's saying. I mean, none of us even wear regular, street clothes anymore. We're all wearing scrubs now because we go home, we're throwing it right in the washer because we don't change for all of us as well. No one's wearing shirt and ties anymore because we don't want to, be carrying stuff and bringing around patient to patient. And yeah, the goggles and masks, regardless of whether you have COVID or not, we're wearing them.
John, any thoughts from you about this?
Yes, thank you. So from a lessons learned standpoint, I think, we were lucky. Dr. Matzinger and some of the other leaders started us about 2 years ago on the HRO journey. So, it's modeling yourself after other highly reliable industries like the airline industry and military. And so with that, one of the items we implemented was a daily safety huddle. And that has become invaluable to us because I start my morning every day putting together reports, doing a state of the house. As Dr. Matzinger mentioned, he leads a call across our system. And, my colleagues and others across the organization have to report out, our numbers of COVID and, our census and availability and any issues. And then we take that back to our daily safety huddle at 9:30 every morning, which occurs across our system. And that's where the frontline leaders are on a call and they're able to give us some feedback, tell us what's going on and express any of their needs. And it's also it's an opportunity for us to educate folks on just state of Virtua, on how we're dealing with this, who's high, who's low, and who's in need of resources so that we can move them around accordingly. So that has become invaluable, and it's a 7-day a week. So we do it Monday through Friday, and then even on the weekends, we conduct it via phone, and it's been very helpful. So,
have you found that your electronic health record and being able to get data out faster and use it has helped you in making decisions and examining where you should be?
I think it has helped us. We have most of the health system on one electronic medical record. Lourdes Health System joined Virtua in July. They were supposed to go live in the middle of this. Obviously, we didn't do that. So we're still working off 2 systems. Where we have been able to do things is by putting in standard process and order sets so that we get some consistency. We can also do data pulls, but I will tell you, we're still reconciling the data pull with what we're seeing live. So John will get a data pull of his COVID patients, but then we ask him to reconcile that with what's going on actually in his building.
Okay. And finally, just from a more human element of this, this has been really stressful for everybody. I mean, whether you're health provider or you're not, I mean, we've all had to make significant changes to how we live and function and work. But definitely if you work in a hospital, it's probably the most stressful. And so I'm wondering how you've been supporting all of your staff. There's the nurses and the physicians, but then there's also all the other people, the transport people. They are kind of unsung, but they also are seeing all this being exposed. And so I'm wondering, how are you supporting them, both emotionally and practically during this crisis?
Sure. I'll mention a few things, and Emilio, would love for you to comment too. So, a couple of things, I guess, just going back to basic leadership, making sure that we're out walking the floors, talking to our staff, letting them see that we're there to support them, asking them if there are any issues, and of course, thanking them. The attaboys and the attagirls go a long way, and just making sure that we acknowledge the great work that they're doing. And then the other thing is food. The communities that we care for, we've been overwhelmed with the support that we've received. We've had parades of fire, rescue, EMS, and police come by the front of the hospital with their sirens on as a salute to the healthcare workers. We've had the mayor come out and paint a green line, down the middle of our street on South Avenue, again, to show the support from the community. We have had neighbors put up signs on their fences, just saying thank you to the staff. And then these folks are sponsoring meals. And so tomorrow is a great example. We have 2 different organizations that teamed up, and they're going to deliver 600 meals to the organization. And that certainly makes people feel good and appreciate it. And I think it's really helped keeping the spirits up. And then lastly, we had a really big celebration for a patient that Dr. Mazza and their team took care of. And maybe I could flip it over to Emilio, and you can kind of fill in a little bit more about that and other things that you're doing to help keep the staff engaged. And
Yeah, thanks, John. Well, I have to say our staff has been awesome. Initially, everybody stressed. We didn't know what was coming, what to do. We didn't know what was going to happen, but they've really all come to really shown up and really have done a tremendous job, between the providers. The nurses have been doing extra shifts, especially because we had 3 ICUs open. Respiratory therapy also is part of it, very, very important. The patient care technicians that go in the room and help the nurses as well. And EVS, our environmental services people, they're cleaning up and they're getting all the garbage and all the stuff, and they're all part of the team. Like ICU care, as I always have said, it takes a village. It's not one person that manages an ICU patient, and everybody has really jump to the occasion, and really it's been tremendous. And all the things John mentioned, all these things that the community has done to provide like food for the nurses. We got a shipment of like hand lotion from one company, that we gave out to the nurses that they to have, because just a little thank you for them. We had a bunch of children make lots of beautiful cards and signs that we posted outside our ICU and on the patient doors, on the outside of the doors, so the patients could see them. Just wonderful, heartfelt cards from anywhere from like 2-year-olds and and little ones and older kids making these wonderful signs, and even adults. And I think that's really helped bolster our our morale, all that support. And John was mentioning the one patient that was that left here that I know is in the news as well. It was really amazing because this is why we do what we do. When we save lives and we can see someone leave, and I think probably the part that touched me the most when she was telling everybody how she loved us back. When she was getting in that ambulance was the most amazing and probably the most touching part of that whole scenario. And it just was, that's why we do what we do. And that really helped bolster morale to see that, what, guys, not everybody dies, and a lot more people survive, and they're doing it, and they're getting out of the hospital. and doing well. So, and I think that really helps more than anything else.
Yeah, I agree with what Emilio said. One of the things that we do every day is we have a communication that goes out across the organization, and it will tell how many people have been discharged, how many cases we have in the hospital. But we've also, we use a lot of video because we are so dispersed. So we have a production studio where we're doing interviews with the frontline staff, with the CEO, doing podcasts with our infection control team. I think a lot of it is getting information out, transparency of information, and then sometimes answering the question why, because there's things changing literally on an hourly basis. And sometimes we forget to tell people why it's changing, and people can be uncomfortable with change because they've done it the same way. It's something, I know it sounds trivial, but we realized that we couldn't reprocess our N95 masks for our nurses because they were wearing makeup. And the makeup was we couldn't reprocess because of the makeup. We sent out a notice to everybody. It says, you can't make this up. And we explained how you couldn't wear makeup with the mask. We apologized. We knew the inconvenience it was causing. But then we decided we were going to give out Sephora gift cards for when you could wear makeup, and we raffle them off every week.
That sounds like an excellent solution to me. So I think we do have some time left where we could take any questions from the people who have them from the audience, given that this is Zoom. There's a Q&A button somewhere where you can type your questions, and then we could read them out loud and answer them. So if anyone has any questions, and I'll give people a minute to see if they want to do this. This is another one of the new things that is going on with Zoom. Okay, here's a question. It says, are affected patients who do not have health insurance being treated? So anybody who wants to answer that.
Yeah, we treat everybody regardless of their ability to pay. We're testing if you don't have insurance. We're offering video chat if you don't have insurance. And if you come into our emergency rooms, you'll be treated like everyone else.
Okay, that's great to know. Other questions that anyone wants to ask? Again, you have to click on the Q&A button that runs along the bottom. Okay. On a larger scale, is there concern among other healthcare systems about reimbursement? So do you know of other, I guess your system is doing that, but do other systems do it? And are there concerns?
Every health system has to treat the patient if they present to the emergency room, regardless of their ability to pay. Health systems have done this. We do it every day, regardless of if you come in with a heart attack, we treat you. And we find the right community resources for you. I mean, I would say, make no mistake about it, this has been an economic hardship for the health systems. It's not because of COVID patients showing up. It's because we're not doing surgeries, and surgeries are our economic engine. And you see your bottom line disappear. On March 7th, our bottom line disappeared.
Here's a question for Dr. Maza. Are you seeing patients with ICU-acquired weakness and post-intensive care syndrome?
Well, to answer the first part of that question, yes, we are. And actually, we're seeing it worse than what we normally would see in a typical patient with ARDS. And, with the, ICU acquired weakness, we call critical illness polyneuromyopathy. We see that can occur because of the medicines, the long-term sedation, paralytics that are given to the patient, and their immobility. But we're seeing it even worse than what we normally would see. And there's a body of literature that's developing showing that the coronavirus itself can cause various different neurologic effects. I kind of alluded to it earlier, but anywhere from patients having stroke to actually having like similar diseases like Guillain-Barré, multiple sclerosis, and critical illness polyneuromyopathy. I have patients who can't even lift their arms up. after they've been on a vent and ill with this. And a lot of these patients are having neurocognitive effects of the virus. Certainly the hypoxemia can do it, but also the virus itself, there's a body of literature talking about how that can actually affect them. I don't know if anybody watches CNN, but even Chris Cuomo was on there and he was talking about how his mind wasn't the same. He just wasn't thinking the same. His mind felt foggy. And it's probably a direct effect of the virus. Some patients are even getting, necrotizing, encephalitis from this, from this virus. And so, so we are seeing those kind of things. Now, in terms of post-ICU syndrome, we haven't seen enough of these patients yet, but I would not be surprised if I would be surprised if we don't see it, because these patients are on sedation, they're paralyzed, they're on the ventilator. These are the patients that do develop the post-ICU syndrome, where they can develop PTSD from being on a ventilator, and they have vivid and horrible dreams while they're on the ventilator, the weakness, and the long-term neurocognitive effects. Just to give you an example with H1N1, ARDS in general, a year after, they looked at a large panel of patients a year after having ARDS, after the H1N1 epidemic that we had. Many patients had neurocognitive deficits, including memory issues. Many of them were left with chronic illness, chronic lung disease, specifically interstitial lung disease, from the injury caused by the virus. And even 5 years out, only 50% of people got back to their baseline in the most severely ill patients. That's 50% of people who don't get back to their baseline. So you can see the tremendous effect it has on public health and in the long term. We see them in the ICU and they get out of the ICU, but there's a long process down the road after they even leave the hospital.
Right. So we actually may have a whole segment of patients, large numbers, that really need rehabilitative care moving forward. A lot of them. John, maybe you want to speak to that at all, but.
Oh yeah, absolutely. If you just think about, the clinical picture that Dr. Mazza just painted, the patient is sitting there not moving for, sometimes 14 days, and put that on top of, what the flu does to people, this type of flu. You'll see, if you see any of the coverage that we've had in the news, on the news and in the newspapers, we're celebrating patients who are leaving and then they're going to rehab centers. They're not going home to home care, right? It's, the evolution of care in America. We've moved a lot of patients right into the home environment, or even tried to accelerate them into the outpatient arena. So I'm sure these patients are going to go through their inpatient rehab stay, progress to home care, and then I'm sure they'll be handed off to the outpatient side to continue in their rehabilitation.
Okay, so Dr. Mills, I think this is probably a question for you. This is regarding remdesivir. Wondering if there's any plans that you know of to do some trials or studies using that drug at early stages with patients to decrease mortality.
Well, right now the trial is going on is a national trial. I know Dr. Fauci mentioned that. He's on that panel at the NIH where they're looking at it. Like I said, right now, as I think I mentioned earlier, it's really being given to the patients who are on a ventilator that are very sick and hypoxic. As far as I know, there's no plans to do it, doing it early on, because part of the problem, part of the issue is remdesivir is an IV med. And I think ultimately what you're going to see is companies are going to develop an oral medication like Tamiflu that can be taken up front and have the same effect, but be able to be given early on and not require intravenous administration. And remember, this drug was designed, for the original SARS and Ebola virus and all, and kind of was in the closet for a while. And then all of a sudden you had compassionate use you were using it for, and then emergency use, and now with the trial. But now, again, they're really reserving it, and the government's really controlling who's getting this and when. But yes, I'm hoping that they'll look and see maybe we get more bang for our buck going early versus late, and maybe someone will come up with an oral type of medicine like remdesivir.
Okay. Here's an interesting question, and anyone who wants to answer it, feel free. Says, I've noticed an ambulance at a neighbor's house twice at night this week. I have no idea if she's COVID-19 infected or not. What do you recommend about leaving her alone versus trying to check in on her? Any suggestions?
That's a difficult question. I think if possible, I'd recommend probably a phone call before actual face-to-face encounters. You're not sure if there's COVID-19. I will tell you that we are starting to see an uptick in non-COVID-19 illness. Remember, people have what we're calling medical distancing. People have not been seeking medical care for over 2 months. So some of the chronic conditions we would see on a daily basis, really we haven't seen. And now in the last couple of weeks, we're seeing upticks. So that neighbor could have heart failure or something of that nature. You don't know, but I think it's probably, if they can get in touch via telephone or with a family member, is probably the first choice.
Okay, that sounds like good advice. So here's maybe this may be our last question. Are there any policy changes that the panelists would like to see to help them in their work? What is their greatest need? Those are excellent questions. So anyone want to start?
So I think I'll just say testing, right? I mean, we hear that on the news, we read it in the paper, availability to test, more and more patients and employees would be helpful.
Okay. Dr. Matzinger, did you have any thoughts on policy?
I would agree with John. Testing is definitely a need. I think to be honest, when we talk about antibody testing, we need to start understanding what that actually confers, and that's going to take some time. We are getting calls, and when I talk to patients, they want antibody testing. There is antibody testing available, but we have to tell them, I had COVID, I have antibodies, I don't know if that works. I mean, it's that simple.
Dr. Mazza, you're at the front line. What would you say your greatest need is?
I agree with everything everybody said, in terms of what we're saying about testing and more universal testing. But I think, I think what we talked about already too, just, I don't know necessarily the policy, but just, I think, as we said earlier, our way to approaching things like we like after the HIV epidemic with universal precautions, I think we're going to have new universal precautions. We're going to be going in wearing masks, and with everybody until, just to, again, to stay safe. And I think that's where some of our policies are going to, change. And even coming to an office visit, I think we may end up happening too. We're wearing masks if patients are wearing masks. But I think for now, that's going to be a good thing until we get we either develop a medication that's going to work that can treat this, or this gets under control. But I think we're going to see a new norm. But I agree with everything they're saying about testing. I think that's important.
Okay, well, I think we've run out of time, and I really want to thank the three of you for joining us and providing this information. I think it really provides, everybody in our community with information that they need to have. So join us next week on May 13th for another live webinar. We're going to address implications for individuals with substance abuse disorders. If you would like to learn more or see a video of all of our work, including these panels, you can go to cph.temple.edu/COVID-beyond. And to support the college or students, faculty, or research, please visit our secure giving page at cph.temple.edu/giving. So stay up to date on the pandemic also through the college's coronavirus resource page. We are posting a lot of reliable information there. We also have videos like how to use a mask, how to wash your hands. That's at cph.temple.edu/coronavirus. Again, thank you to our panelists. Thank you to Virtual Health. for everything that you're doing.